So next I would like to invite Dr. Rohit Pandey. He's going to speak on how to use a table for DA.
So very good morning everyone. I would like to thank A.S. Prasad sir and UP Arthroplasty Association for the opportunity. So as we know, we have so many approaches for the hip, but we are going to travel a road which is less traveled. But we have to understand that whatever road we are taking, the final outcome of a hip replacement remains the same. That you need a well-balanced hip with optimum limb length and a proper positioning of the implant with a longer survivorship. So we have questions in my mind that whether we can use conventional instruments and implants for the same, and is it always required a special instrument for these cases? Because the problem is that at most of the places you don't get all the offset reamer and the other important instruments which are required for a direct anterior approach. So as very nicely explained by the previous speaker, the Hutus approach has been described in the 19th century, and it is a internervous plane. The superficial plane is in between the TFL and the sartorius. And once you go deeper, it is in between the rectus femoris and the gluteus minimus. So as the superior part is supplied by the femoral nerve and the other is by the superior gluteal nerve, and you go in between the muscles, so you don't cut any tendon or any muscle in this approach. As compared to the Smith-Peterson approach, it is a little bit more lateral, known as the Hutus incision, which is round about 2 to 3 centimeter lateral and distal to the ASIS, and the incision goes on the lateral femoral cortex or the fibular head. Just for the finding of the plane, if you give the incision and you find a thin fascia, so you are on the TFL. If the fascia feels more thicker, then you are more medial, so you have to remain lateral to that. And in this video, as you can see, once you get that incision, you can use your fingers and you can identify the plane and you can just get in between the TFL and the sartorius. If still you are confused at where you want to go, you can feel for the ASIS, because the sartorius arises from the ASIS, and then you have to remain lateral to that. The next step is to find the lateral circumflex femoral vessels. If you don't find them, they are definitely going to find you, and they may cause postoperative hematoma. So either you can ligate them, cauterize them, whatever you like, you can do that. Then you can remove the precapsular fat, and then there is exposure of the capsule, and you can cut the capsule as also described. You can do an inverted shape or any shape what you like. Either you can remove the whole of the capsule or you can preserve it also. The results are not that much different between the two. So it is the way I open the capsule. Following which, if you have the traction table, then you have the liberty of giving the traction. You can do the neck cut and you can remove the femoral head. And as you can see in this picture, I am just using all the normal, means the posterior approach instruments, and the acetabular view in the direct anterior approach is very good as compared to the posterior approach. But if you have that angulated Chanley remus, that gives you additional advantage and the exposure is a little bit better, but you can still get away with the normal implants. The other problem which comes is the offset reamer, because the femur comes in between the reaming. And if you use the offset reamer, that makes your life easy. But again, here you can see in this picture that I have a straight reamer available because it was not available in Varanasi where I practice. So I was able to get through with this also. It makes life difficult. You have to push more inferiorly, but you can get away with it. And if you have the proper patient also. So in the acetabular reaming, what you have to understand that you have to prevent means excessive anteversion, and the anterior reaming should not be more, which is the tendency in the direct anterior approach. Coming to the femur, it is just looking at the thing from two different angles. So we have to make our awareness to see the femur like this. If you are able to visualize the femur like this, and you know this slide is very much important for the early beginners for the direct anterior approach. Where are the iliofemoral, ischiofemoral, and the pubofemoral ligaments, and how it is attaching on the femur once you rotate the femur. I guess the other talk is all about the femoral releases by Saurabh sir, so he will discuss. But little bit, just initially you have to get little bit of external rotation and feel for the LT that you can release, and then hyperextension and release of the superior structures can be done. Now here comes the role, means initially what you have to do is, after doing the releases, what you are able to do is to pull the femur more laterally and upwards. And if it is above the half of the acetabulum, then your releases are complete. And then comes the part of the orientation, which is the posterior part, which is anterior and which is medial and lateral. And you require curved instruments, but if you have a traction table, means these are the offset broaches and all, if it is there, very good. If it is not there also, and you have a table, that gives you that advantage to do the case without the special instruments. So it is a modified table which I have got custom made. I have applied for the patent also. So this I am using right now, in which you can get the you can give the traction, internal external rotation, and hyperextension to the hip. And this is the position of the femur. So what advantage gives this table is that you can give at least 60 to 80 degrees of hyperextension also, which makes the femur almost vertical. So the curved instruments and the special implants which are required, you can get away with the conventional implants also if you are using this table. So external internal rotation can be given, hyperextension can be given, and adduction also you can increase. As compared to a normal table in which the hyperextension is around about 30-40 degrees only, and the adduction also becomes a little bit of problem. And while giving the traction and reduction, if you have the table, it makes life easy. So with the traction table, you can use standard implants, hemiarthroplasty is possible. You can do difficult and revision cases also, and there are less chances of femoral fracture. These are few of my cases in which you can see that intraoperatively, acetabular reaming, broaching, you can see post-operative X-ray, and you can also do hemiarthroplasty, which I am doing fairly nowadays because most of the patients which we get are neck of femur fractures mostly. This is a fairly recently case done in which I have done a hemiarthroplasty using a cemented normal implant. Difficult cases also, as has been described, is being done by the direct anterior approach now. This is a hip dysplastic in which everything was done through the direct anterior approach. So the advantages are, it gives better initial recovery. It's a minimally invasive technique with no muscle cut. You get the anatomy of the acetabulum very nicely, and intraoperating imaging also you can get. So finally, modified traction table makes life easy. Special instruments are helpful but not mandatory. Standard and revision implants can be used. Longer learning curve on the femoral side. Is the view which you prefer. It is not everybody should go for a direct anterior approach. You like the posterior view, the lateral view, or the anterior view. It's all your choice. So thank you so much for your time.
Thank you. Thank you.